Hello everyone. So today's topic is neuroendocrine tumor of the stomach. Gastric neuroendocrine tumor is a rare type of cancer that originates in the neuroendocrine cells of stomach, and these cells respond to gastrin. So anything that increases gastrin increases ECL cell stimulation. Gastric neuroendocrine tumors are usually well differentiated, slow growing, and behaves differently from pancreatic or small bowel neuroendocrine tumors. And we broadly divide them into three types: type 1, type 2, and type 3. So there are three types. Type 1 is most common, which is seen in 70 to 80% of this neuroendocrine tumor, and it is because of the chronic atrophic gastritis. Because of that, there is low acid and it leads to high gastrin level, and this high gastrin level produces multiple small polyps in body and fundus of stomach. It has indolent behavior and excellent prognosis. Type 2 MEN associated is seen in 5 to 6% of the cases, and it is due to Zollinger-Ellison syndrome, which is also known as gastrinoma plus MEN1, and it has high acid, high gastrin level, and there are multiple lesions throughout stomach, and it has intermediate malignant potential. Type 3 are rare, which is a sporadic type of NET, and these are 14 to 20%, and it has normal serum gastrin level, but they are usually solitary, more than 2 cm in size, and behaves like gastric adenocarcinoma. They have higher risk of metastasis. Type 1 are autoimmune gastritis, and they have achlorhydria, increase in gastrin, ECL cell hypoplasia, and it leads to neuroendocrine tumor. Type 2 are gastrinoma, having increase in gastrin level, increase in acid, and it leads to ECL hypoplasia, and then they produce neuroendocrine tumor. Type 3 are sporadic tumor, not associated with gastrin, increase in gastrin level. Most gastric neuroendocrine tumors are asymptomatic, and if symptoms occur, they are usually due to dyspepsia, bleeding, iron deficiency anemia, rarely carcinoid syndrome. It is only seen when metastasis is to the liver. So diagnosis involves upper GI endoscopy for type 1 and type 2. There are multiple small nodules. For type 3, usually has a solitary large mass. Second thing we do when we see on endoscopy, if there is any lesion, we take biopsy, and it confirms neuroendocrine tumor plus Ki67 grading. If it is less than 3%, it is grade 1, 3 to 20% is grade 2, and more than 20% is grade 3. Third thing we do is serum gastrin level. It is high in type 1 and type 2. Type 3 has normal gastrin level. The antiparietal cell intrinsic factor antibodies for type 1, which is autoimmune gastritis. And imaging, we do CT MRI for staging, and gadolinium 68 DOTA TET PET, that is for somatostatin receptor positivity, and endoscopic ultrasound for depth and nodes. So type 1 neuroendocrine tumor, they has best prognosis. If the lesion is less than 1 centimeter, we do endoscopic removal and then keep patient under surveillance. If there are multiple small lesions, we do endoscopic mucosal resection or endoscopic submucosal dissection, and avoid surgery unless the size is more than 2 centimeter, submucosal invasion, lymph node involvement, and enterectomy is rarely used nowadays. Type 2 is MEN1 related, and we treat the gastrinoma, that is primary cause. resection of the dominant gastric nodule lesion which is more than 2 cm size, and control acid secretion by giving PPIs, and also we need to do N1 workup. For type 3, which is aggressive type, and it is treated like gastric cancer. It requires gastrectomy with D1 plus D2 lymphadenectomy, and consider systemic therapy if metastasis is there, and poorer prognosis is seen as compared to type 1 and type 2. So type 1 neuroendocrine tumor has excellent prognosis with less than 5% risk of metastasis. For type 2, the risk is intermediate, and type 3 has having worse prognosis with the 30 to 50% present with metastasis at the time of diagnosis. So if we summarize everything, most common type is type 1, and type associated with man1 is type 2. Most aggressive is type 3. Highest gastrin is seen with type 2. Achlorhydria is seen with type 1 and needs gastrectomy in case of type 3. Thank you for watching, and if you want more surgical oncology short lectures, subscribe to my channel and drop your topic request. Thank you very much.